We're now going to have Scott Montagne, who's going to present on the current update on HPV vaccination in low-resource countries. Dr. Montagne is a senior technical officer for HPV vaccines at PATH, and for the past 5 years, he was the research manager for PATH's HPV vaccination demonstration projects. He also serves as a member of the Gavi HPV sub-team, and he holds an affiliate assistant professor position with the Department of Global Health at the University of Washington. Thank you, Scott.
Well, good morning, everybody. Thanks for coming out so early on a Saturday. Thanks for the organizers for the opportunity to speak with you about the global experience for HPV vaccine introduction. It's an exciting time to be in this field, and hopefully by the end of this presentation, I'll be able to communicate that excitement to you. We were told to disclose our financial interests, which are zero for me. To give you a sense of where my presentation will take you, I want to first give you an overview of where we stand right now today in terms of introduction of HPV vaccine around the world. Talk a little bit about some of the challenges that we thought would be important to overcome in order to implement this vaccine in a low-resource setting. Give you some experience from our own demonstration projects as well as others that have happened around the world. That experience is only going to be focused on what's been published in the peer-reviewed literature, although there's a lot more experience out there, and I'll talk a little bit about that in my remarks. And then try to give you a peek into where we are heading next. So this is a map of the global experience for HPV vaccination thus far. What you see on this map are 52 countries now and territories, if you consider the Marshall Islands, that have introduced HPV vaccine in their national program, their national immunization program. 52 out of 198 is actually a pretty good number, I would think, 5 years after a vaccine has been licensed and approved. But they're not the only ones with the experience. There have been several countries within this group that represent low-resource settings. So Guyana, Lesotho, Rwanda have fully national implementation programs for HPV vaccine, and Uganda has just embarked on a phased scale-up for national implementation. So we're starting to see this take hold. There's been lots of pilots done. In fact, there's been 24. Actually, there's been more than 24, but 24 in addition to some of the countries that have introduced nationally, which started as a pilot and then graduated to a national introduction. So there's been 24 pilots around the world. You can see on this map, they are a range of different countries, both low income as well as middle income. A focus in the dark green here are those countries that are in the lowest resourced countries, and there's quite a few of them that have embarked on this mission to try to pilot HPV vaccine in some capacity to learn from that experience to see whether or not it's appropriate for their country to introduce. This is a full list. It's getting rather long now. I don't think I'll be able to use this slide much longer if we have any more countries introduced nationally, but it gives you a representation now of almost 80 countries, again out of 198 member states of the UN that have experience with HPV vaccine. So it's becoming something that's not necessarily new anymore, which is great, but also has its own unique set of challenges, which you'll see in a minute with some of the results. So when we were discussing this is now years ago, we came up with this very abbreviated list of potential challenges. The goal for many countries when they do these pilots is to see how they can overcome these challenges. What are different ways in which you can mitigate the negative impact of what has been perceived as something that would be a barrier in order to turn that around into a leverage point for success. Things like, and you've heard these before, it's not on the infant immunization schedule, it's for girls only, it's a sexually transmitted virus, and you don't see the benefits till way, way, way later, unlike some of the other traditional vaccines. Will these be a problem? Well, I've showed you just before that there's been almost 80 countries that have experience with this vaccine and 52 have introduced nationally. So people have figured out how to overcome these challenges. And those are some of the data I want to present to you today. So the pilots that have been done thus far have mainly followed two different structural models. The first one is a kind of an approach that we did, which is a little bit more systematic, where you're looking at grounding the pilot in a conceptual framework for its implementation. The goal of our programs were really to generate evidence at a population level. So these are population-based interventions in order to learn and inform. which is a little bit of different approach than traditional research has taken. Often you have a hypothesis or a question you're trying to answer, and that was not necessarily the case in driving our research portfolio. Lots of the work has been published, and I'll reference that as we go along. The second type of pilot is pilots that have been done basically from donation programs, and these have really focused on giving an individual opportunity to receive this, what was at the time perceived as an expensive vaccine. So provide the benefit to people who otherwise would not have been able to receive that benefit. And most of that has been driven on a sort of service delivery model where you have a fixed set of vaccine and you want to disperse all of it. So you have 5,000 doses. You say, okay, I've got 5,000 doses. The first 1,500 girls that come in get the doses, and then the doses are over. So that's a sort of another model that has been used for countries and programs in areas to gain that experience necessary to see how they can overcome the challenges for implementation. We've had a couple of other different strategies along the way, hybrids and mixes of this, that, and the other. But overall, those two ones, the demonstration program at a population level and an individual service delivery model, are the primary ones in which countries have gained experience. We've recently seen the publication from Debbie and her team from Tanzania, which was actually a randomized cluster trial. So that's an approach that has been used for HPV vaccine implementation. And then there's been an interesting program that started in Nepal. I don't know if anybody from the Australian Cervical Cancer Foundation is here, but this is a program where another NGO buys the vaccine in their mother country and then takes it with them to a low resource setting and helps them implement it in that way. So quite a different variety, but what's interesting to me is the experiences and the lessons learned are quite common across them. And I'll point those out along the way. So here's just a summary of the kinds of programs that have been looked into. You could see in this slide that they range in size, small programs, about 1,000 girls, very large programs, like 30,000 girls. They're mainly using schools as a way in which to find the eligible girls, and they're mainly targeting a population that's within the recommended WHO guidelines of girls that are ages 9 to 13 years old. The scale is different across these different countries. Sometimes you use a lot of schools, sometimes you don't. Sometimes you use a lot of health centers, sometimes you don't involve them whatsoever. But the important point being is that people are trying a lot of different ways in which to try to see how to implement and overcome the various challenges that have been previously identified. I'm highlighting our work in black just to sort of that's our reference point, and to point out the difference between those programs and others in the model of a more service delivery. And again, all of these examples here on this slide are just from the published literature. As you've seen before, there are 24 countries that have done these pilots. There's only about a dozen listed here. So there's another dozen out there that have this experience but has not yet come sort of into the international awareness level. I know about them because I talk to them, but it's not something that's easily disseminated for many people. Our model, as I mentioned before, was one that was very strategic, and its goal was to generate evidence. For that, you have to do formative research in advance to see what the framework of the communities are like, and the health systems, and the health worker environment, and the policy environment. So it's a very dynamic and tiered understanding of what people know about cervical cancer and how best to implement this vaccine, and what would you need to do to implement it, et cetera. Then those data that are generated from that formative research design the program itself. So the communities tell us how they think you should implement the vaccine. The health workers tell us how they think you should implement the vaccine. And then you design a delivery strategy and a communication strategy and an advocacy strategy accordingly. Then that needs to be tested rigorously in a demonstration program. Ours was population-based, so that everybody that was eligible in an entire geographic community was targeted, whether they were in school or not in school. And then you evaluate them. And I've given you the references on this slide, and I'm happy to give them to you after the presentation. I know it's probably a lot to take in right now. One of the common themes that was really interesting, we weren't quite expecting in advance, was that everybody, really everybody, said it's a vaccine, it belongs in the vaccination program. Now, we had some suspicion in advance that perhaps maybe this is a reproductive health issue. Maybe it should be delivered by the reproductive health department. Or it's a child health issue or an adolescent health issue. Maybe it should be an adolescent health program sort of standalone. It's cervical cancer prevention. Maybe a cervical cancer control program should take the lead. But in fact, when we talked with communities and health workers and government officials and people at all levels across the 4 countries we worked in, the common denominator is the perception that it's a vaccination and it belongs in the vaccination program. So all of our pilots are actually run by the vaccination programs in that country with their health workers. Nobody was hired, no additional staff capacity besides training was performed in order to us to see whether or not you can overcome some of the challenges to do the implementation. For those that don't work in immunization programs, they're very structured. There's a common methodology that's used across all immunizations, and it's kind of schematically drawn in this slide, where you identify who you need to treat, who you need to get, and you educate them, and you train the health workers, and you got into community and do the vaccinations, et cetera. It's a very methodical process. I'm going to walk you through it with some images from our work in our 4 countries. Training health workers is critically important, obviously, to give them the skills and the information necessary to be able to do the implementation. And this is not just skills and information about HPV vaccine and cervical cancer prevention, but also skills and information about how to identify girls who are eligible for the program as the government has defined them to be. So if they're in grade 5, how do you determine that? If they're 10 years of age, how do you determine that, et cetera? So really skills on a wide variety of components necessary for them to do the implementation. There's a micro-planning process that is common across all immunization services, where right down at the lowest level, it's determined which health workers are going to which place at which time for which vaccine. It's often done annually, sometimes more than annually. It's always done before a campaign. And this is something that communities and regional governments and national governments are very, very familiar with this process. So we did the same thing. That's our micro-planning chart from one of our districts in Uganda, actually outlining the health worker's name and what schools that health worker will go to. Community mobilization and sensitization cannot be under or overemphasized in this regard. It's important that a comprehensive approach be used with multiple modalities and leverage points. It could be leaflets, it could be radio spots, it could be announcements from television, it could be announcements at church, etc. A lot of different ways to organize communities, make sure the cold chain and all the supplies are in order prior to vaccination. A visible launch can be critically beneficial because it provides that endorsement that this is a government program, that it has legitimacy, that it is, we government have already reviewed it and say it is safe for you, etc. So visible launch was often a part of programs. Monitoring and doing the data collection during the immunization program itself is really extremely important and common across all vaccinations. And then finally, you've got to dispose of all the waste products afterwards. We hope in the end you come up with girls who are happily vaccinated with all 3 doses. So how do we get there? What are some of the lessons that we've learned from these pilots, and what have we, how can we translate those lessons for other programs that are ready to get started? These are data now from the published literature related to the pilots that have been occurred so far. And you can see there's quite a variety of successes in terms of achieving 3-dose vaccine delivery across multiple settings using multiple different delivery strategies. On average, about 80% reported vaccine uptake for all 3 doses. Now, whether they're getting the 9 to 13-year-old population varied quite a bit across the different pilots, but for the most part, they were quite successful in achieving a target group that was in line with the WHO recommendations. We did population-based coverage surveys for our pilots. I think we're the only ones that's actually done community-level population-based coverage surveys before. And you could see these data also validate what has been reported in the administrative data, which was on the previous slide for uptake, which is about 80% overall, with some variability across delivery strategies that I'll mention when we talk about the feasibility. Recently published data from Tanzania is also included on this slide that W. Watson Jones have done and looked at coverage of the school-based strategies that they did, selecting by age and by grade, and over 70% in both of those strategies. So clearly, we've learned a lot about how to access this population. That barrier, I think, we know a lot about. In terms of acceptability, there's some common themes. What's surprising to me when I first started to read other acceptability studies post-vaccination, not intend to vaccinate, but after vaccines are offered, why do parents say yes and why do parents say no? That the information that we had learned from parents that we talked to was very similar from parents from Rwanda and Tanzania and Fiji and other places that have done these pilots, which is great because it's affirming and tells us what are the positive leverage points you need for a parent to make a decision to accept HPV vaccine. There are things like messaging around cancer. There are things like endorsement by the government. Things like involving lots of different people who the parents trust as a part of the communication delivery strategy. These are things now that you can take in other settings, and when you design your communication strategy, make sure that these are incorporated because you might have a higher likelihood of success. It's not without its challenges, and there are some parents who say no. So why do they say no? Sometimes it's because they just don't have the opportunity. They don't know about the program, so the message hasn't gotten out or been disseminated properly. Sometimes they're fearful of some of the side effects or the impacts that the vaccine may have. You can overcome that by talking about those in advance in your communication strategy rather than waiting for the issue to be generated. And then another big problem, especially for school-based delivery, is girls may not be in school the day that the vaccination is offered. And we've seen this in other studies come out. You need to offer it more than once if you go to school. Kind of a mop-up is what they call it in the immunization world. For feasibility, there's lots of positive leverage points to make programs successful. Close coordinations with the schools if you're doing school-based delivery, making sure that you prepare well for the exercise in advance, meaning don't rush it. Get all your health workers, and again, if you're in schools, make sure you also train teachers for the implementation, not just the information about it, but also the sort of the program mechanics in terms of implementation. The visible endorsement I talked about as an acceptability leveraging factor. It's also a factor for feasibility. If the government doesn't own the program, and if the health workers don't know that the government owns the program and they're not behind that, it could create challenges for the health workers in terms of them taking on and owning that program locally. You do need to do your cold chain assessment in advance. Most of the pilots that I've presented have been quite small, so the cold chain capacity has been less of an issue because it's a small amount of vaccine, and it's only in the cold chain 1 or 2 or 3 times. But when you're scaling up nationally, this is a serious issue, and there's lots of tools available for countries to do that. We costed our program, and I'm not going to belabor the point, but you can design a program where the financial costs can be reasonable. For implementation, the scaling up of this is the next step. And these data are also quite similar to ones that have just recently been published out of the Tanzania trial. So we're sort of on mark, about $1.50 to $2 a dose for delivery. And the vast majority of that cost is startup. So when you think about it in terms of recurrent expenses, we're getting to the point where these things can be affordable. So what have been the barriers identified thus far? I've talked a lot about what are the leverage points, but we shouldn't forget that there's still things to overcome, right? We can try to work around and build programs to be successful based on what we know works. But when you do that, you still have to keep in the back of your mind the things that haven't worked and make sure you sort of cross-reference those things in your program design. So if you don't have government support, if you've got a powerful media that's not very supportive, if your messages are not answering the questions that parents want answered, if you don't provide opportunities to catch girls in other venues and in other ways who might miss the main vaccination program, if you don't closely coordinate with your schools, if you don't know how to determine who's eligible, these are the kinds of things that could really hiccup your program and make it not be as successful as it can be. So lots of things have been done. We've got an amazing amount of experience now and more being generated every day. It would be great for all of those countries that are doing these pilots that are not yet in the peer-reviewed literature if we can help them along that process, because it really helps inform the evidence base and gives us a lot more publicly available data to work from. High uptake, as you've seen already, can be achieved. I don't need to belabor that point. I will talk a little bit about acceptability, though. One of the other things that's important is that you give parents the time to make a decision. Often, sometimes they find out about the program the day before, and that has been difficult in many settings. You really need to do your communications to communities in advance, so parents kind of They take that information in, they think about it a little bit, they talk to their neighbors, their aunties, their friends, their families, their health workers, their teachers to get validation of their decision, and then they decide. It's a two-step process for parents. It's not just, this is great, and everybody says yes. If this is great, oh, that's great, and now let me think about it, and then I'll make a decision. Lots of things can work. They don't all have to be school-based. I showed you several examples where the health center-based strategies are successful, but they've designed that success in the context of that local circumstance, and other countries would need to do the same in order to make that successful. And the government support, of course, is highly critical. So where are we going next? This is the map that I've showed you earlier in the presentation of the now nearly 80 countries that have some experience with HPV vaccine. And I'm happy to report there could be another 16 getting that experience next year. 13 of them are in sub-Saharan Africa, and 3 are in the Near Asia and Southeast Asia regions. I can't show you who they are because they're applying to Gavi for funding, and that information is not yet in the public domain. But it will cover many countries who have very, very high rates of cervical cancer, which is the important goal of this intervention. If we are able to scale up at this pace, this is some projections that have been done by Gavi for the countries that they work with on the impact that we could have. And the impact could be almost 2 million deaths averted over the next 20 years or so. So it's really, we're at a juncture, as I mentioned at the beginning, an exciting time of scale up in a way in which we probably haven't seen in a long time with vaccines of this nature. And you are lucky to be a part of this field at this time. Thank you.